Right. It's my great pleasure to introduce the first speaker of the day, Andrea Maier, who is coming from Singapore. So Andrea, whenever you're ready, please go ahead.
Yes, thank you so much, and thank you for coming. Hello, Rafa. Very great to see so many people and so many smiling faces at this beautiful conference. So thank you so much to giving us the floor. And not only yesterday, the Health Longevity Society and the Health Longevity Day, but today really, for me at least, talking about interventions, which is dear to my heart. But most importantly is this slide. I love this tattoo. I don't have tattoos. I very often get the question while showcasing this photograph. But it's very important not only that we are living long, but that we are living healthily for longer with a very good quality of life. And one of the factors having a good quality of life is not only have a functioning body, but also have friends. And I think this conference is so nice that we all meet. And I think it's always one of my events I'm really looking forward every year. So thank you so much for sharing the time. I again start with the ecosystem we are going to change in Singapore. So you have seen the slide yesterday. Today I will really focus about the core of doing interventions. So we have preclinical research being led by Professor Brian Kennedy, and then the clinical research. I will talk about intervention studies. We are bringing it into practice and changing hopefully the public health sector to bring health and longevity into the ecosystem and into the world. While having and investing in diagnostics and interventions and having the Academy for Health and Longevity. So yesterday I talked about the biological, clinical, and the digital phenotypic characterization of individuals, which is, I think, hugely important, and today I will touch on especially supplements and a little bit of repurposed drugs. But before doing so, I think it's very important to notice that before we give any intervention, is that we are diagnosing something. And I don't care, and I think we had a huge discussion yesterday what kind of clocks to use, and nobody, I think, has the truth, and there is no truth yet, what kind of diagnostics to do. But I think we have to phenotypically characterize our individuals either in practice or in clinical trials thoroughly. So that's also the reason why we have to look at, I think, at all physiological systems we have in our body. And we should not neglect, for example, even our mouth, our oral health, or the women's health, or the male's health, or our pulmonary function. So phenotypically characterizing is very important. HLMS, so the Health and Longevity Medicine Society, really wants to invest to bring the diagnostics or bring working groups together to talk about diagnostics. So if you're interested, please let me know. If you want to learn about women's health and how to maybe implement it either in your clinical practice or in your trials you're doing, please look at the poster of Dr. Ayla Hotchkiss-Courage. She is a postdoc in my lab, and she is sitting there with a very red jacket. So please have a look. So let's talk first about nicotinamide mononucleotide. You might have heard that there's lots of commotion around supplements, and especially NMN, that it might be banned from the market, etc., as a geroprotector. I think NMN has a potential for some of the individuals I see in clinical practice to really improve the health. Why? Because NAD levels are going down with the chronological age. This is a nice paper, 2015, by Eric Verdun. He is also here, I think, in the audience, really nicely showing that NAD levels go down, and while potentially increasing the NAD levels, we could have very positive effect, a pleiotropic effect to lots of organs in our body. So there was the hypothesis, of course, is if we give NAD precursors, for example, NMN of NR, that we restore NAD levels and therewith restore health. So we did a trial, it's published in Geroscience last year, where we gave NMN to individuals, 80 individuals at the age of 50, all were healthy, and it were 4 arms, so we had placebo, and then we had 300, 600, and 900 milligram of NMN, and the primary outcome was NAD levels to really showcase, okay, can we increase NAD levels? And the secondary outcomes were clinical outcome levels, like a 6-minute walking test a quality of life scale, and then the Sino clock, which I think you all know. What we were able to show is that, yes, NAD levels are going up, and especially in the group of 600 and 900 milligram, but there was also dose responsiveness and showcasing that 300 milligram also increases the NAD levels. And very luckily, but cautious, because this is a small study, also the 6-minute walking test and the quality of life was improved in the individuals at 600 and 900 milligram. But what we also showed is that, and this is so nice if you have different dosages, that 600 gave actually the best result. There was not an increase or a better effect if people took 900 milligram compared to 600 milligram. However, 600 milligram was better than 300 milligram. So we were quite, of course, pleased with that result, but then we thought, okay, we see so much heterogeneity in the NAD level increase of individuals, and that's seen on the left-hand side. You see this huge arrow bars that we said, okay, but some people, either they don't take NMN, and therewith they do not have NAD levels, but just now think about, okay, they would take the NMN, that there's a huge variety, especially in 300 and 600 milligram. So we ask ourselves, is there a dose relationship in terms of how much NAD levels are going to raise, so the delta, compared to how good the clinical outcome was? And that's what you see in the table, really showcasing that if the NAD level increase is higher, then it's a higher likelihood that the clinical outcomes are much, much better in these individuals. And then we said, okay, but how much should an NAD level change? And that's what you see on the right-hand side in the figure. It's roughly 50 nanomole per liters of change in NAD level, where there's a chance that 50% of the individuals had a clinically important or significant increase in these outcome parameters. So in the 6-minute walking test and the quality of life. So I think that's nice, because for the first time we show that there's not only a dose relationship between MNN and the clinical outcome, but especially also the surrogate marker of NAD levels. I'm an internal medicine specialist, so I love it, because normally when I treat diabetic patients, I always measure the glucose level, I give insulin, and I measure the glucose level again. So what we really try to establish here is measuring NAD levels and then titrating the NMN and measuring the NAD level again. So that's what we are going to do, also with an NI algorithm, an accurate, where we hopefully get funding for two, but we will start anyway. And then we will do that in 40 to 60-year-old individuals. Before starting the trial, we thought, okay, which supplement should we use? And we thought, okay, we do not know which one is the good supplement. And what we did, I see lots of cameras now, because this is exciting, because I think you would like to know which supplement should I use. We looked for a nice study, in my view. I'm not sure how many friends I have after showing you this slide, because we analyzed, okay, what's outside written on the bottle, is that the same what's in the bottle? So in summary, we were looking at the label claim. And we are now also looking at contaminants to be tested. And this is done by my dear colleague Enilar Sandalova, also working in my group. So what you see here is just 10 NMN supplements. We have many more which are now being tested. And what we looked at, okay, what is the label claim? How much NMN is really inside, and what's the percentage in the end? So this is a huge table. We summarized it here for you. So you have the different NMN products, and everything which is greenish, bluish is good, everything is red is not good. So what you see is out of 10 tested products, 2 had no NMN inside, but it was a label claim, and I would say 3 were quite good, and the rest is so la la. So I think it's, yeah, I don't have words for it, because I think this is possibly a quality problem in our field. So before testing anything or taking anything, please test it. Okay, we also do that for other supplements at this moment in time. We do a study, and these are just updates, what kind of randomized controlled trials we are doing at this moment in time. Alpha-ketoglutarate has a pleiotropic effect, very likely really reshaping the epigenetic makeup. That's very, also for longevity clinics, there was a very nice supplement if somebody has a higher epigenetic age, that it could influence that clock positively. We are doing at the moment the ABLE study. And the design of the ABLE study is quite unique because we are not only including just healthy individuals, conventionally healthy, being 40 to 60 years of age, but we are selecting the ones who have a higher biological age being measured by 4 methylation clocks. And then from the 4 methylation clocks, we are taking the median, who are biologically older compared to their chronological age. So that's our inclusion criteria. So screened for every age-related disease, no diseases, and then we are taking the ones being biologically older. Our primary outcome is also the median of these epigenetic clocks. And I think we are now the first trial to really selecting our individuals based on clocks. So it's a little bit, it feels like jumping into cold water, but let's see what it is. Our secondary outcomes are the general ones, all organ systems, including oral health and other factors I think we should not miss. We just got 2 grants, which is very exciting to also test alpha-ketoglutarate perioperatively. On the one hand side, in colon carcinoma patients undergoing surgery. On the other hand side, recently we got the funding for patients who are undergoing cardiac surgery. So we are giving 4 weeks of alpha-ketoglutarate 1 gram before that operation, and then really test if the resilience is better of these individuals. We are also very interesting to not only look at specific hallmarks of aging, for example, senescence, but also to see if food could be a very nice sort of supplement we always take to antagonize our aging process and being used as geroprotector. So what we did here, and this is a systematic review, really looking at what kind of nutritional ingredients do we find in our food being tested either in animal studies or in human studies with senolytic or semnomorphic potential. And what you can see here is there is lots of evidence, or not lots, compared to other specialties, but there is evidence in animal studies, and everything what's green, there is a significant influence of the senescence while treating especially mice with these kind of nutritional products. However, there is really not much in humans. So this really showcases that we have to translate from animals much earlier, I would say, to the humans, because nutrition, I would say, is quite safe to give and to learn from our colleagues who do the preclinical studies. We also did that for very specific parts of the body, for example, the brain, because there is lots of investment, also financially, of course, giving more money to brain researchers. So there's much more evidence. And here we really looked at the GSK3 pathway and especially compounds who could inhibit it. Why do we do these systematic reviews? Because we would like to know what our next leads could be in randomized controlled trials. And you just see on the left-hand side the pathway, on the right-hand side possible ingredients where it's coming from. This review only had animal studies inside of it. So there is not much evidence in humans. Again, there is a translational problem. Just recently, we looked at the serotonin pathway, which is also important not only for the aging process in general, but especially for cognition. And we did the same, just seeing, okay, what kind of evidence is out there in animals to translate that in humans. Again, here, no human trials included, and just a sort of evidence based on animal studies. We are embarking on lots of trials using repurposed drugs. One of them is Rapamycin. In my group, we always start with, okay, let's look at the literature, doing systematic reviews. Most of the times we cannot do meta-analysis because the evidence is not there. That's the reason why we are summarizing in these kind of figures, showcasing that, yes, we already have 19 studies only in humans looking at Rapamycin or Rapalogs as geroprotectors, which is great. However, what we see is that the evidence is quite limited at this moment in time, especially seeing positive effects in the immune system, nervous system, and the cardiac system. But what we also showcase here again, that if it's tested, and lots of human randomized controlled trials using geroprotectors show the same, that we are not looking at all our organ systems. We could easily measure, for example, the respiratory system or the digestive system, etc. So I think here's the best opportunity to really showcase that geroprotectors really influence the health of our entire body. We are doing the longer study. If you want more information, also Ayla is sitting in the corner. It's a double-blinded randomized controlled trial, 6 milligram of Rapamycin to 40 to 60-year-old healthy individuals, so really healthy, to see if we can change the needle in terms of the biological age. I'm very sorry, I have to leave. I would really love to stay here, but I have to leave this afternoon because on Thursday we are opening our longevity clinic in Alexandra Hospital, where not the primary aim, but the secondary aim is, of course, to recruit lots of individuals to our trials, but especially, of course, to showcase that we can change the biological age of individuals in a generally publicly funded hospital. We are including 400 individuals. We are enlarging that to 3,000, and we are doing lots of cost effectiveness and implementation science analysis. And very nice is that the delegation of Klaus Schwab from the World Economic Forum will come to open it. I would love to see you in Singapore. So I see lots of cameras here. So there are QR codes. We have a conference end of February just dedicated to supplements, because I think that we really have to learn what to take and not to take. So our sessions are designed as first the preclinical evidence, then the clinical evidence, then the regulatory evidence, can we use it, not use it, what kind of regulatory actions should we do, and then ending for most of the supplements with a systematic review, showcasing where the evidence summarized really is. So hopefully that will work. It's a trial out, but would love to see you. 3 days before that conference, we have the NUS intensive course of health longevity of our Academy for Health Longevity. It's a new academy, really for educational purposes, 3 days intensive. We only have 100 places there and 300 in the conference. Hopefully we will see you there. Thank you.
Thank you so much, Andrea. Really inspiring talk. Do we have a question down here?
Andrea, thanks. Great talk. I hope I didn't miss this in the presentation, but I was wondering, in your NMN trial, was delta NAD correlated with NAD levels at baseline?
No association.
Okay,
that
thanks.
was in a slide. Yes, no. So also the NAD levels at baseline was not predictive for example, outcome, which is, I think, a pity. Just to discuss it a little bit further, because I thought first I measure NAD and then I decide if I should give NMN or not, which is not the case. So therewith, in the clinic, I think what we should, and we do it in a trial, we are first measuring, we see what the delta is, and we would love to have that 50 nanomole per liter, and we cannot just look at a level in the beginning. It's not associated.
Okay, just a simple question. Why on rapamycin are you trying it on very healthy people who typically have a very good mTOR and therefore shouldn't really see much benefit, as opposed to people whose biological age is a couple of years older than their chronological age who might see a benefit? Yes,
good question. So in the ABLE trial, we are now looking at conventionally healthy individuals and selecting them based on the biological age. There are two reasons, and they're not valid reasons scientifically, I can tell you. It was too much for our ethics commission to actually see we want to have healthy and then adding a biomarker. So the ABLE trial is the first one getting through the ethics, that a primary selection criteria is a biological clock and an outcome parameter. And we already submitted the longer study before even thinking about. So it's also a learning curve for us, yes. And we will absolutely do the post hoc analysis to see if the biologically older have much more benefit. And that will, again, help us. Yes, absolutely. But if we show that in the AKG trial, it doesn't mean that it also holds for other interventions, of course. So I think it's really a learning curve. And I must say, I would rather now do a study being possibly a little bit underpowered, but giving me the breadth of individuals being included to get that feeling what works and what doesn't. Yes, then selecting and just knowing it only works in biologically older individuals. And the other thing is also, nobody has the truth which clock is really the right one. So it's really jumping into the water and putting all your money and effort into, yes, only a couple of clocks.
All right, thank you so much, Andrea. That was really amazing.
Thank you.